All right, well, we're going to go ahead and get started unless there's any objection, but we want to get moving to use everybody's time and respect everybody's time this morning. I'm Gene Ransom with MedChi, the Maryland State Medical Society, and we're here this morning with Jessica from CRISP and Will from HSCRC, and we're going to do an overview of the Episode Quality Improvement Program specific to urology. And I'd like to thank, obviously, MedChi and the Maryland Urology Society who jointly promoted this program this morning. Having said that, I'm going to go ahead and turn it over to Jessica to start. Go ahead, Jessica.
Good morning, everyone. Thank you guys for being here today. We have an agenda today where we will be reviewing our EQIP program, get into some detail about the policy and methodology, and also talk about timeline and next steps. Feel free at any point to just either put it in the chat or jump right in and ask a question. No need to save something till the end, and we will get started. So let's talk about EQIP. So under the Maryland Total Cost of Care model, the priority is reducing costs and improving quality in both hospital and non-hospital settings. Due to our model, historically, some specialist physicians have been ineligible to participate in national Medicare value-based payment programs. Therefore, the state went about with the goal of creating their own program focused on specialists. This is the EQIP program, and it is the very first specialist-focused program that is designed to achieve both cost and quality outcomes both in and out of hospital-based settings. So there are four main features that we'll emphasize in today's presentation. First, that this is physician-focused. We really wanted to create a program that physicians can own and monitor their own performance. Second is that EQIP was designed to have an upside-only risk. There is a Dissavings Accountability, which we'll talk about later. But since it's the first program of its kind, we wanted to design it to be very attractive to join and allow physicians to get familiarized with this type of value-based program. Third, EQIP was also designed to be aligned with CareFirst episode payment program. So EQIP has a similar design and approach to reduce, with the goal of reducing the administrative burden across the different programs that physicians may be participating in. And finally, EQIP gives participants the opportunity to take part in an advanced alternative payment model where they can be eligible for a bonus if they qualify for quality and savings goals. And finally, the underlying methodology we're using to define episodes in EQIP will be the PROMETHEUS episode grouper. We'll go into much more detail later in this presentation, but just that is sort of the foundation of this program. And for the first year, which is ongoing now, the three specialty areas that were selected were GI/general surgery, ortho and neurosurgery, and finally cardiology. So if we take a step back and look at what we mean when we say EQIP is a value-based payment model, there are really three main outcomes that better define value and what we hope that EQIP achieves. Now, the first, you can see we increase quality while cost remains the same. The second one is to keep quality the same level while decreasing cost, or in the ideal state, the state that we hope EQIP achieves is we increase quality while decreasing cost. When it comes to value-based payments, the EQIP program is a bundled payment program. So across the nation, bundled payments have proven to be effective to help control costs and improve quality. CMS has actually shown a 4 to 6% reduction in their bundled payment programs, which is why we designed EQIP in a similar model. Now, there's three primary elements of the EQIP program. First, each physician basically agrees to participate in the episode-based payment. Now, using a baseline period, the cost for that episode would be calculated to identify an appropriate target price. That target price would then be used to assess performance, and then the performance year costs are compared to that set target price to identify if savings were achieved, and therefore if participants are eligible for incentives. So the idea here is to sort of have this straightforward program so that, again, physicians can monitor their performance and track success. Now, I mentioned CareFirst a few slides back, but let's talk about this a little bit more. So since EQIP was designed as a multi-payer demonstration with CareFirst, What that means is that the HSCRC and CareFirst worked closely to align their programs, specifically the definitions, so that there can be parallel incentives and similar design elements. Again, the goal is to make this as easy as possible for physicians who may be participating in both programs. At the fundamental level, the Prometheus episode grouper is used to design both programs. However, it's important to note that EQIP will have a separate policy decisions and incentive payments. But again, the core principles and design are very similar and gives the opportunity to create rewards across both Medicare and commercial programming.
Now, Jessica, there was a question, and I was a little slow in the draw in telling you, but Dr. Bengal wanted to know, is the target price flat across all providers, or is it provider specific?
So it is a little bit of both. So there's a target price set at the EQIP entity level, and I am going to talk about that in much more detail. So if I don't answer it, we can follow up with those questions, but it's sort of at the group level, and we'll explain that in a second. So I just mentioned some words and probably a couple different words, and policy loves a lot of acronyms. So let's start with some definitions that will help when I explain some of the policy and methodology side. So first, you'll hear a term that's called a CRP entity. And this is essentially a single Maryland hospital that will sign a standard contract or an arrangement with any eligible physician in the state that wishes to participate in the program. Basically, the CRP entity is what the state is using as a solely administrative function to be able to pay out incentive payments to the participants. Moving to that next column, an EQIP entity, so you'll hear this a lot, the entity is the main participation function of the program. So an EQIP entity can be an individual physician, or can be a group of physicians, a practice, a subset of practice. It really can be any grouping that a physician would like to participate in as an aggregate. And it's important to point out that the EQIP entity is the level in which we assess performance evaluation. And again, it's always at the aggregate level. So essentially, the EQIP entity will receive a lump sum incentive payment based off of the aggregate performance at the EQIP entity level. Now we get into care partners. So this is essentially what we're calling our specialty physicians. These are the people actually practicing medicine, performing the care interventions. Each care partner, so each individual, is required to sign a standardized agreement with the CRP entity. Again, care partners, physicians continue to receive their normal fee-for-service payments from Medicare, and this potential incentive payment is on top of your typical billing practices. Finally, you have us, HSCRC, and Chris, who are the main policy drivers and the ones who will actually calculate episodes, monitor your performance, and determine your incentive payments. The HSCRC and Chris are responsible for maintaining most of the monitoring and reporting requirements to CMS for participants. So we really want to minimize any reporting burden placed on the EQIP entities. Now, this last row at the bottom here is called an administrative proxy. And this is a support role for an EQIP entity, so they can delegate the management of the program how they see fit. So this could be your practice manager, it could be an external consultant, really it's whomever an entity would like to engage to help them manage participation and performance in the program. So the CRP entity, again, as I mentioned, this is one Maryland hospital that's taking on that CRP entity role for the performance year. For year one, it was the University of Maryland Medical Center. And really, this is the core partnership that enabled EQIP to be recognized as an advanced alternative payment model with CMS. Now, while was selected, any qualifying physician in Maryland is eligible to participate. And it really does not matter if they have a prior or current relationship or even have privileges at UMC. A physician really could technically have never touched the hospital system and are still allowed to participate. And this is because that CRP entity or UMC has two main roles. First, they receive a list of the care partners who choose to participate, and they generate that standard contract or care partner agreement for them to sign. And second, they were the ones actually distributing the checks for the earned incentive payments. So it's important to note here that UMC will not be calculating those payments. HSCRC does this. And essentially tells UMC to pay each entity a specified amount and ums will cut that check. So again, we want to really emphasize that UMC will not have access to any protected health information. There's no data sharing agreements that need to happen between the individual physicians or their practice and UMC. They also will not have any access to performance analytics and are quarantined to those strictly administrative functions that we just discussed. So we want to emphasize that policy decisions and support comes through HSCRC or CREST. So participation requirements. So this is an important bucket. First, all physicians must qualify as a care partner with Medicare. And what that means is that we need our physicians to be up to date in the PICO system. And this is a very crucial piece in the CMS vetting process. We also require that care partners use CERD or EHR and CRISP for the health information exchange. Now, the second bucket is the enrollment requirement, which begins with defining that EQIP entity. So physicians must determine if they are enrolling in EQIP as an individual or with multiple care partners. From there, an entity, so your group, will select the episodes and interventions and agree to the quality metrics they would like to participate in. Then they sign a care partner arrangement. Again, every individual signs a care partner arrangement or that standard contract with the CRP entity, UMC. And finally, the entity as a whole determines where that payment will be sent. Again, as a reminder, payment needs to be sent to one single source across all care partners in an EQIP entity, regardless of it being one individual person or 100, 1,000 care partners. It's one single location for the payment. Now, this final episode threshold is determined strictly based off of Medicare, Maryland Medicare beneficiaries. For a single episode, the HSCRC requires a minimum of at least 1 episode in the baseline period. And then in totality, for all the episodes that an EQIP entity elects, we must see at least 50 episodes in baseline. And again, this is at the entity level. So again, if you are one physician, you have to individually meet that 11 threshold and then 50 threshold. But if you are a group of physicians, the 11 and 50 still stand for your group as a whole. So for example, if an EQIP entity selects 4 different episodes, each of those 4 episodes must have a count above 11, and adding the quantity of the episodes in the baseline for all 4, there must be at least 50 to participate. Okay, so the other piece of enrollment is that there's a selection of interventions. And we've talked about this a little bit more. Basically, this is what an EQIP entity selects as performance improvement opportunities that they will implement to achieve the goals of improved quality and reduced cost. And you can see there's sort of 3 main categories: clinical care redesign. This could be discharge planning. It could be a standardized process for provider follow-up. The second one is beneficiary and caregiver engagement, really focused sort of around education. It could be in-home assessments that are conducted pre-surgery, things like that. And then finally, we have our care coordination and care transitions. This could be a care manager that is assigned to follow a patient across different settings. It could be an interdisciplinary team setting that's put into place to discuss the patient needs. It could be sort of a multitude of different options. Just as a note, the EQIP program is a site-neutral program. So the selection of the most cost-efficient and high-quality setting of care is a performance improvement opportunity. This could mean, when appropriate, shifting from a more expensive hospital unit to a hospital outpatient unit or an ASC, which would help manage the patient's acuity while also saving on costs. Okay, so let's get into these episodes that we talked about. You can see here, these are the 15 episodes that were selected for performance year 1. They were rollover to performance year 2. You can see that we mainly in year 1 selected procedure-based episodes. The number following each episode is the length of the episode, or basically how long the beneficiary's costs will be tracked as part of the episode. Now, getting into year 2, we have a list of ED episodes that we are going to implement and have worked to develop. And finally, more important to you guys, here are the proposed ones, Prometheus episodes from performance year 2. We do want to note there is a specialty name assigned to the left, but we are well aware that sometimes this actual specialist may not be the one following that patient within the episode. It's just the sort of closest alignment that we could get. So you can see here down at the bottom in the sort of urology category, there are 4 different Prometheus episodes that were categorized as urology: a catheter-associated UTI, just regular urinary tract infection, a TURP, and then a prostatectomy. I apologize if I'm saying that wrong, which is the only procedure-based one. And just as a note here, again, we have a lot more detail behind this, and the Prometheus model is kind of complex, but as a sense, at a very high level, you can see here sort of the categories of either triggering procedures or ICD-10s that fall into those 4 different urology episodes. And again, we have a lot more detail behind this that we can share at a later time. And then Will, I'm going to pass it over to you if you want to talk about new episodes.
Great, thank you, Jessica. So as Jessica mentioned, we looked at the Prometheus episodes and tried to find the ones that would most closely match different specialty groups. I think we definitely know that the specialty groups are not the only ones that are going to perform those episodes, or even those episodes might not be sort of modally performed by that specialty group. So UTI is an example. I think the messaging that we've got from others is UTI is typically handled by somebody with internal medicine specialty, something like that. And so this was just sort of our closest matchup between the Prometheus episodes and specialty groups. That being said, we are happy to develop any additional episodes that would better fit your specialty group, if that's something you're interested in. And there we would not be limited to the Prometheus episodes. Next slide, please. Sorry, Jessica, could you advance the slide, please? Thank you. So if you're interested in developing your own episodes, if you have a procedure or a condition in mind that you think you could improve quality or reduce costs on, we'd be happy to develop those episodes for you. In order to do so, we would need 3 things from you. The first is a list of ICD-10 codes that is used to identify when the procedure begins or when the episode begins. The second is an attribution rule to determine which physician the episode will be assigned to. This can be very straightforward. So for example, the rendering physician on the claim, or it could be a little bit more complex. We've been talking with some other physicians about doing glaucoma episodes where there's no clear procedural trigger for when somebody starts managing a patient's glaucoma. And so there we've been discussing attributing episodes to the physician that provides the majority of the E&M claims, for instance. Or we could use any other attribution method you guys specify or are interested in. And then third, we would need the list.
How are you doing? Very good. I am so sorry.
No worries. Or the third thing that we need is a list of ICD-10 diagnosis codes that identify which costs are relevant to the episode, and so which costs you'd be responsible for managing as part of the episode. Next slide, please. That's it. So back over to you, Jessica.
Thanks, Will.
I wanted to add one thing. If something is a Prometheus episode, it can be included relatively quickly from a timeline point of view. If there's a desire to develop something new, just expect that it could take a long time to work with CMMI and work with HSCRC and work through all the process to get there. So I just to set expectations, if that's something that you want to do, it's not going to happen overnight. So I think that's important to understand.
Absolutely. Thanks, Jean. So let's get a little bit into the meat of this and the details about the policy and methodology. So looking at the EQIP policy, there are really 2 main buckets of the methodology. First, we previously talked about is the actual Prometheus episode definition. And this is where the episodes are developed, triggers are defined, and EQIP will use the relevant cost methodology to build out that episode. The HSCRC does not dictate the policy around the episode builder, but rather we contract with a vendor that owns the Prometheus episode definitions. And I say that with an asterisk because, as you can see, we've also developed some of our own. The second part of the methodology is where the HSCRC and CMS policy lives. And this is where the parameters around target price, shared savings, measures that are selected for quality, reporting, monitoring, that's that whole bucket of area. And of course, the state's policy with CMS, which includes our QP status. So if we first look at the left-hand bucket, so the Prometheus episode definition bucket, just as some background, it is an episode algorithm that has been in development since about 2006. It was recently acquired by Change Healthcare, who is the vendor that currently owns the algorithm. So one of the primary reasons for selecting the Prometheus episode grouper is that it really does promote coordination and collaboration across the continuum of care at the provider level. In its years of development, it really has had a goal of pinpointing what costs are actually relevant to the episode and therefore align with physician accountability for that episode. Another positive we talked about before is algorithm already has 97 different episodes that have been developed. We're utilizing 15 performance year one, but it really gives us that opportunity to rapidly expand or add on new set Prometheus episodes in the future performance years. So this flowchart is sort of a high level view of how the Prometheus methodology assigns services. So as with everything, we sort of start off with that total cost of care to make sure you're looking at a full view of what's happening for a population. From there, the Prometheus looks at what costs are really relevant to the episode, what those relevant diagnoses to the procedures, what relevant services, and how they identify those. This is typically done through ICD-10 coding or CPT codes. And then from there, relevant episode costs are split into two buckets, typical care and potentially avoidable complications. Within the typical care category, you have this idea of core services or other relevant services that you've already been doing for your patients. While still falling under typical care, the Prometheus methodology does help identify potentially overused services and setting selection opportunity. And this is potentially where we see that opportunity for cost and quality improvement. An example could be certain labs workups are being potentially ordered too frequently compared to your peers across the state. Or again, that setting of care could potentially be shifted to a lower acuity, lower cost setting. And these insights that Prometheus pulls from all the relevant costs show the opportunity for savings and quality improvement within the program. So that other bucket, one of the key aspects of the Prometheus methodology is that idea of potentially avoidable complications. And this is where you start to look at alignment of negative outcomes or experience for the patient with the cost of care. Now, if we get into a Prometheus episode, it really centers around providing specialists with the relevant data of the episodes they're accountable for and can give them the level of detail that they can see how their practice compares to the state. So the way that this is done is that episodes are triggered. This is usually triggered by a procedure or diagnosis, and then the episodes potentially have a look back and a look forward period. So both of those periods are configurable based off the episode. Now, the pre-trigger period for a procedure is typically 30 days, and this is a period it's set to capture any pre-surgical care, for example, labs, radiology workups, et cetera. And then that post-trigger period essentially is following that beneficiary for a set period of time and counts all that relevant cost within that time period. Now, the post-trigger period really can range from, I think the lowest is 14 days and the most is 180 days, but we see typically around 30 days for procedure-based episodes to be the average. And again, the Prometheus model really combs through all the claims and aggregates them into the episode to determine what the relevant costs are. So analysis across the continuum identifies opportunities for those cost savings and quality improvement. So we talked about the procedure-based episodes, but there are other different types of episodes here. So we do have chronic episodes, and this is an episode based on a discrete event. They may or may not have the same triggering event as a procedure episode. Therefore, as Will mentioned, we have to sort of identify a alternative attribution rules. And we talked about sort of two different ways, the sort of plurality of the E&M codes, or potentially looking at assigning that attribution with the highest E&M cost. So just as a note, an implication of this attribution is that that attribution is applied retrospectively at the end of the episode based off of the claims during the episode. So that means that a physician may not know whether a patient is attributed to them until after the course of the episode has completed. However, the goal is to attribute that episode to the physician with the most responsibility for that episode and that patient. And then the episode, though chronic, for all other intents and purposes, functions as a procedure episode. Now, target price. So this is a question earlier, so let's talk about that. The target price methodology. And again, this sort of we moved out of that initial Prometheus episode bucket, and we're into the HSCRC CMS bucket as far as policy. So basically, the state has determined a methodology to determine if incentive payment should be earned. To do this, they first set a target price based off of baseline episodes. For new episodes, the baseline is calendar year 19, and it will be the same baseline period for the first 3 performance years for those who join in the first year that that episode is offered. Now, each EQIP entity, again, the entity is assigned their own unique target price. And to do this, the HSCRC looks at basically a weighted average cost per episode of all the care partners within an entity and aggregates it to create a unique target price for that EQIP entity. That target price is then trended, or that baseline cost is trended forward to make it comparable to the most relevant year's cost. And it allows entities to compare sort of their real-time target price to the real-time performance cost. However, it is important to note that the final target price is not done until the end of the year, when that final inflation can be applied. Now, as I mentioned before, entities that join after the first year that the episode is offered, their baseline period will be the year prior to joining the program. So for example, if someone joins in performance year 3, which is 2024, sorry, their baseline will be shifted up to the 2023 year. So that 2019 baseline only serves an opportunity for that first year of participation for those EGO entities that join in during the first year of participation. It's also important to note that target price is set independent of the care setting. So that means across all the different settings that a practice may provide these episodes, hospital outpatient, inpatient, ASC, we keep it on a singular target price. The reason behind this is that we want the cost to follow the physician and to be measurable across all of your business. And additionally, due to the model, we know that the gap between a hospital procedure and an ASC procedure is far larger under our Medicare fee-for-service schedule than in commercial payers. So we want to align incentives between physicians and hospitals to shift to that lower acuity procedures, shift lower acuity procedures to that lower cost setting when appropriate. And we want to make it advantageous for both specialist physicians and the system as a whole. So the incentive payment methodology, target price comparison really is that first step in the incentive payment methodology. So at the end of the performance year, we assess the results seen across all episodes within the EQIP entity. And if the aggregate across the EQIP entity performance period costs are less than the target price, we would determine that a savings has been met. We do a check of at least 30% of savings. And the reasoning behind this is to ensure that savings is considered statistically significant. Once that check is met, the savings really fall into 3 tiers for shared savings. So using baseline data, EQIP entities will have been compared to statewide experience and essentially ranked on efficiency. This rank will give us the relative shared savings that will be paid out. So for example, our higher cost providers that are ranked lower, and that's a lower percentile is shared. Now, lower cost providers that are ranked in the higher percentile have a higher shared savings. So if we go down this list, the lowest ranked percentile and the bottom tertile has a 50-50 split with the state. The entities in the middle have a 65% split with the state. And finally, those that fall in the top tertile will have the largest share of savings that will give them an 80% of the savings that they create. And we do this because we realize that those high performing or low cost providers during baseline may have a more difficulty to achieve additional cost savings if they're already considered relatively efficient. So therefore they have a higher shared savings for those that have been achieved. The third bucket here is we fall into the clinical quality score. So quality is a very important component to both value-based payment models, but also ensuring that outcomes of the program are not only cost focused, but again, aligned with patient outcomes. So therefore, 5% of the shared savings is sort of withheld and earned back pending assessment of the 3 quality metrics. Now, this last step is this incentive payment cap. So the state needs to check and ensure that the calculated payment is no more than 25% of the prior year's Part B payment. And this is really a CMS stipulation, but ultimately it does give a stop gain of 25% of last year's Part B payments. Again, that'd be a very, very large payment, so we doubt that that will be an issue, but it is a final check. And basically, all of those things are done. The HSCRC directs that CRP entity to pay the incentive payment, again, one lump sum to the EQIP entity. And it's done towards the end of the following year after the performance year ends. Okay, not hearing any questions. So that was sort of a lot. If we walk through a kind of simplified example, let's take this example right here. We have an EQIP entity that is participating in 2 episodes, episode A, episode B. Their baseline costs are $15,000 and $10,000 respectively. For the purpose of this example, we are not including inflation just to keep it clean. So you can see that the target price for the performance year is also $15,000 and $10,000. Again, are in the real EQIP that cost is inflated to match performance year costs. So moving on, we see the volume that they saw during the performance year. We multiply that actual volume against the actual cost, and we get the aggregate actual performance year episode cost. That's in line E here. And you can see that we compare that and determine if savings were achieved, so that you can see in line F the actual savings achieved. Now we do this sort of 3% threshold check. Yep, they met that, we check that. And then we look at where they fall within that shared savings. For this example, I believe we put them in the top tertile, so therefore they are due an 80-20 split. We apply that 80% savings, and we get $34,000 as the hypothetical incentive payment that is paid out. Again, in the real time, we also ensure that that falls below that 25% cap, and then we do the 5% held back for quality. But this is sort of a simple rundown of how that incentive payment calculation works. So at the very beginning of this presentation, and one of the great things that we're committed to is that EQIP is designed to have an upside only risk, but we do have a Dissavings Accountability that's worked into the policy. And basically it's important to drive meaningful improvements in cost efficiency and quality and keep CareFirst stringent standards on enrolling in the program. So therefore in lieu, there's this lieu of downside risk, there's this Dissavings Accountability plan. And basically any EQIP entity that creates a Dissavings in a performance year will be required to offset those savings in the following performance year to earn an incentive payment. So in future years, that flowchart mapping out of that incentive payments will include an additional step in the performance data to determine if there's Dissavings that need to be offset from the prior year. Now, an EQIP entity can be removed from the program if they already fall in the lower 2 tertiles, so that 0 to 66 percentile, and there have been 2 consecutive years of Dissavings. So the logic here is that since EQIP is upside only and we're offering that AAPM status, we want to ensure that providers who participate are participating not only for that opportunity, but also to actually drive down costs and improve quality. Now, the reason we exclude the top tercile of performers is because, again, if that entity is already very efficient in the state, it's harder for them to create savings. And therefore, we don't want them to be penalized for sort of falling into that top tercile to begin with. So we did mention that EQIP is an advanced alternative payment model, or AAPM. So let's touch base on this a little bit more. What this means is that care partners who participate in the program are eligible to qualify into the quality payment program. And the quality payment program benefits participants in a couple ways. So the first is a potential incentive payment, which is in addition to the EQIP incentive payment. The QPP status also means there's an exclusion from the MIPS reporting requirement and payment adjustments. And just as a reminder, we are subject to CMS policy here. So if there is a potential for that incentive payment is received in 2024 for those care partners that were participating in this year in 2022. So just as a note there. Okay. So quality. We talked about that percentage of shared savings at 5% that's being withheld and sort of earned back pending performance and quality metrics. So when selecting these quality metrics, the HSCRC really wanted to choose metrics that can be applied effectively at the physician level and that can be measured off of claims data, and that's again to reduce any reporting burden on the entity. Secondly, we wanted to align with criteria with CMS and QPP. So therefore we looked at sort of some high priority and outcomes-based measures. And we did need a minimum of at least 3 measures available. Finally, we really wanted to choose metrics that were agnostic to the episode type. So there are not sort of disparate quality metrics applied to different episodes that are selected. And then finally, we wanted to align the state's larger population health strategy, which is called SIHIS. Now, these 3 measures for the performance year will be advanced care planning, documentation of current medication in the medical record, and preventative care screenings around body mass index. Now, again, these 3 measures will be the same regardless of the provider specialty or which episodes or even how many episodes they have chosen to participate in. Again, these measures are used to calculate that 5% earned back adjustment on the incentive payment calculation. And again, we'd like to highlight that for each of these triggered episodes, the measures, these quality measures are assessed by determining if any physician, so this does not have to be the physician that triggered the episode, it does not even have to be a physician that's enrolled in EQIP, but any physician performed that quality metric a year back, so 365 days prior to the end of the episode. So again, we really want to incentivize that coordination across the care continuum with other providers who, for example, might more frequently do these quality services, but again, the accountability is still at the EQIP entity level. There. So timeline and next steps. So just as a note, the state has developed sort of this one-stop shop, what we call an EQIP entity portal to support participation. And this is where EQIP entities will enroll. This is where CMS vetting is held. Contracting support is held here. And ultimately, it is also the portal in which performance and baseline analytics is housed. So this is a portal that is hosted by CRISP. So just as a note, for organizations that are interested, you guys can contact equip@crisphealth.org, and we can ensure that any paperwork that's needed to get sort of that CRISP access started is underway before the performance year starts. So EQIP does have an annual opportunity to enroll. That enrollment period is relatively short, though. It's July through September of each year prior to the next performance year. So for episodes that are beginning in 2023, it is this summer, July through September 2022, in which you can enroll. So you can sort of see the timeline here across the different ones. So where are we now? I guess we're in late spring. So this is where we are, early spring, I don't know where we are. We are sort of developing the finalized episode selections. We're in this sort of recruitment informational sessions. We can start any credentialing, which I just talked about beforehand, to sort of get ahead of the game. And then finally, in July, when the portal opens, this is when people can enroll. It does close on September 1st, which allows us enough time to go through the CMS vetting process. And basically the time between September and the end of the year, again, that vetting process is done, sort of finalized selections of episodes, et cetera, are completed, and that care partner arrangement or that contract with UMMC is submitted. And we're all set to go by January 1st of 2023 when performance year 2 starts. And again, we sort of restart this cycle again in July of 2023, the performance year 3 enrollment opens. And then again, late 2024 would be when incentive payments for performance year 2, calendar year 2023 would be distributed. And finally, just as a note, we are happy to do more one-on-one conversations, demos with your organization, talk through any actual opportunity analysis specific to the physicians in your group. As a note, we do have a monthly subgroup meeting. It's typically the 3rd Friday of every month. A lot of information is shared here. We recommend it. I mean, it's open to everyone. It also is recorded, and we thank MedChi for hosting that. Just as a note, the next meeting is May 20th, and you can email Barbara to be added to distribution list. And really, any follow-up questions at the end of the day, we like to point people to this equip@crisphealth.org email. We will direct you to the right person or potentially facilitate any meetings that are needed. And the HSCRC website, and actually I should put here, the MedChi website also has a plethora of information from prior meetings, documentation on policy for this year. There's a lot that already lives there, but again, we're happy to help with anything. I think that is the end of my presentation. So if there are sort of any questions, feel free to unmute yourselves. We're happy to answer anything.
Any questions from anyone?
And if I...
Oh. Yes, we can send a copy of the slide deck to everybody. That's not a problem at all. In fact, Ginger, why don't maybe we can do that through the registration. Anything else?
Hey, Jessica, is the model change, as the model for EQIP evolves, is CareFirst committed to modeling the same changes as well? I know you guys did the same episodes, right? But as something gets added to EQIP, does that automatically mean CareFirst is going to be working on adding that? Or are they still separate?
So they still are separate. Again, they use, even for year 1, there were some overlapping episodes, but some episodes that were offered strictly by CareFirst and some that were also strictly by HSCRC. But it's the commitment to using the Prometheus model. So that 97 episodes that are available that will be standardized and CareFirst is committed to using as well. We have engaged them and, we're in conversations, but again, there's no commitment necessarily for us to roll out the exact same episodes.
And just to add on to that too, for example, the ER episode, which was not a Prometheus episode, which is going to be developed and is going to be submitted, the ER doctors and ASEP met with CareFirst and got an agreement from them that they're going to do it. I do think, and this is one thing that MedChi, we negotiated the legislation around value-based payment. One of the agreements we have is that we're going to try to work with them to figure out how to facilitate communication, because we are going to have divergence, but the more we can get one set of measures for our physicians to use and one set of kind of a game plan, the more efficient it becomes. And we want to see if we can't create that. MedChi is also reaching out to other payers and the MCOs to see if they would be willing to try to create uniformity. We did not do a good job with that with primary care, and every insurer has their own primary care program. CareFirst is wildly different from the Maryland primary care. So I think everyone is trying to learn a lesson from that and do a better job on the specialist side.
Thanks.
Just a quick question. Is there any leeway inside the waiver to do things that aren't necessarily in Medicare policy with regards to site of service? Specifically for one of these 2 bundles, prostatectomy is a procedure that's not allowable outside of a hospital setting currently in CMS. which is a little bit backwards and not the way that a lot of people are starting to practice. But, you know, for instance, in the framework of a CareFirst discussion, that can be done is to potentially move the cases outside the hospital if appropriate, which is obviously a good source of savings. So I don't know if there's any leeway on that level of discussion.
That might be a Will question.
Yeah. So in general, no, but it is something that we are interested in working on for the longer term development of the waiver. I think what we would like to do and what we're planning to do with Gene and others as we think about the next phase of this model is try to collect from folks the different changes in either Medicare payment policy or other aspects of Medicare rules that we would like to modify as part of the Maryland model. And so site-based rules, then patient-only list, et cetera, might be things that we want to change there. So I don't know, Gene, if Katie has talked to you, but I think at some point we're going to put you on point for, you know, speaking with your members and trying to collect ideas about what additional flexibilities would be useful, you know, in 23 onward or 24 onward.
And then, of course, we're happy to do that. And maybe we can add that to a future EQIP subgroup meeting as well.
So I think the answer to your question there is at the moment, no, but we do have flexibility to evolve this model in the future, and that could be an area that we focus on.
And Dr. Lowentritt, too, I would also suggest if there are things that there are some loosening of some things as a result of being part of the demonstration project and everything. So knowing exactly what it is, we should at least talk to the staff to find out what rules need to be waived and what might already be waived. So I think identifying them now and sooner is better, so we can ask for them next year if we need to.
Thank you.
Any other questions? Well, I guess we'll just say thank you to Jessica and Will for presenting, and thank you to the Urology Society for helping promote it with us. And I really appreciate all your participation. If anyone has other questions or wants additional information, they can always reach out to me or Jessica, but that email address she showed you in the last slide was probably the best place to start, the EQIP at CRISP Help. And you really should check out the HSCRC and MedChi websites. On the MedChi website, it's under the Center for Value-Based Payment. And there's all the videos of the prior EQIP meetings are on that website as well. So thanks everybody for participating, and we will send out the slides to the people who registered. All right.
Thank you.
Have a great one, everybody.